It's 2 p.m. Eastern time. So good afternoon, everyone, or good afternoon, good morning, everyone, for certain regions, I believe. So we'll just start soon with this webinar on this new funding opportunity from NIH HEAL Initiative. So let me just check one stuff. Okay, I think we should start. Okay, again, good afternoon or good morning, everyone. And this is a webinar on the new funding opportunity announcement from the NIH HEAL Initiative on understanding individual differences in human pain conditions. So let me just give you the logistic issues. Next slide, please. So yeah, this webinar will be recorded, and these recordings and the slides presented here will be posted on the NIH HEAL Initiative websites, as well as the PDF slides for this presentation will be emailed to all the registered attendees. So we ask all the attendees to please keep yourself muted throughout the presentation. And during question and answer session, we can unmute you if you want to directly ask the question. But we would like to encourage everyone to submit the questions through the Q&A feature in the Zoom. As we receive the question, it will be answered in the same order. And we are encouraging all the attendees to really email RFA contacts for consultation regarding your proposal. I know some of you might have already written to me. So once this webinar is done, I will schedule discussions individually, whoever is interested in knowing a little more on the this specific funding opportunity announcement and the program details and applications that you plan to prepare. Next slide, please. Yeah, continuing with the webinar, what we want to cover, we'll just go through the panelists here, and then what are the participating NIH institutes and centers, and we'll take you through briefly on the NIH HEAL Initiative and the pain research priorities in the NIH HEAL Initiative, followed by a description, goals of the specifically this funding opportunity, and some application information and key dates for those applications, then briefly about the review criteria, and finally we'll go to a Q&A session. So next slide, please. So yeah, here are the panelists. So myself, DP Mohapatra, I'm a program director in the NINDS and also a program lead in NIH HEAL Initiative programs. With me, I have my colleague, Dr. Sarah Waller. She's a scientific program manager in NINDS. So I would like to ask Sarah to unmute and say hello to everyone.
Hi, thanks, DP. Thanks everyone for joining us either this afternoon, this morning, today on the webinar, I guess.
Yeah, and also joining us is Dr. Rachel Weinberg. So she's a health program specialist, and she will be coordinating this program, this specific RFA-NS program. So I hope she's here. So Rachel, if you are here, you can switch on your camera and just wave.
Good afternoon, everyone.
Yeah. Okay, so with that, the next level of contacts are the individual program contacts from the individual NIH institutes who are participating in this funding opportunity, starting from NINDS to NIDCR, NIDA, NCCIH, NIAMS, NCI, NIAAA, NEI, NHLBI, NIA, and NICHT. Just to clarify here, this is a HEAL Initiative program. So you do not have to really focus on, oh, I have to stretch my application or my focus area to any specific institute or center to have a different funding decision. That is not the case here. So this is a trans NIH IC program. So you do not have to worry about where it would fit in which institution's mission. So just communicate with us, and we'll tell you which one might be a better fit, but the fit is more on the application assignment. It has nothing to do with the funding decisions or review or anything. Okay. So next slide, please. Yeah, so a little bit about the NIH HEAL Initiative. So as we all are aware of the opioid epidemic and public health crisis in the United States that continues to evolve rapidly and overlaps with many other significant health challenges, such as associated undermanaged pain, as well as mental illness, and many more. So to address these complex health-related challenges, the NIH HEAL Initiative has put an aggressive trans-agency effort to speed scientific solutions to stem this national public health crisis and opioid epidemic. So under this initiative, researchers are taking a variety of approaches focused at improving the prevention and treatment for opioid misuse and addiction, as well as understanding, managing, and effectively treating pain to address the opioid epidemic. Next slide, please. So to expand a little more on the pain management side, specifically enhancing pain management, the NIH initiative has been emphasizing on 4 major areas, like efforts to understand biological underpinnings of chronic pain, to accelerate the discovery and preclinical development of non-addictive pain treatments, and then advancing those non-addictive pain treatments, as well as other new non-addictive pain treatments through clinical pipelines, and also to inform best practices for effective pain management while minimizing the risk of addiction. So more information on all these preclinical, translation and clinical research in pain, and the focus of those funded programs, as well as the overall program within HEAL Initiative, we really encourage you to go through these website links where you can find the details on that. So next slide, please. So let's go straightway onto this RFA. So towards the NIH HEAL Initiative efforts and better understanding of the biological underpinnings of chronic pain, and all the way to inform best practices for effective pain management, this new funding opportunity has now been published with a focus on understanding individual differences in human pain conditions. So the goal of this funding program is to really support research aimed at understanding inter-individual or between person differences in human pain conditions, putting the focus on whole person health there as an approach. So this program or funding opportunity will support studies that will focus on collection of clinical and or preclinical data, which will enable more mathematical, statistical, or computational modeling, and in order to understand the biological mechanisms and psychosocial aspects of pain occurring with use of pain therapeutics, other therapeutic modalities or management modalities, as well as could be a second pain condition, could be a comorbid health condition, or comorbid mental health condition to be specific, as well as other substance use and abuse conditions such as opioids, alcohol, or other substances of use or misuse. So that's the overall goal of this funding opportunity. So next slide, please. As you can see, we are focusing on both clinical as well as preclinical side, particularly on the clinical side. So this RFA has clinical trial optional, but only 2 types of clinical trials will be accepted under this RFA. So they are mechanistic trials and basic experimental studies in humans are called as BESH studies. So let me give you a little bit more and very specific, to be very specific on what is a mechanistic trial. So the mechanistic trials are the studies that are designed to understand the inter-individual differences in biological or behavioral, psychosocial processes, the physiology of pain and other comorbid conditions to be studied, or the mechanism of action of an intervention. So what it would support is how a pain intervention works, but not whether if it works or doesn't work or if it is safe. So your mechanistic trial should be conducting studies focusing on utilizing the therapeutics or pain management to understand how it works and how that contributes to the inter-individual differences and the biological and psychosocial behavioral processes underlying. For the basic experimental studies, so these are research studies that involves human subjects, which would seek to understand the fundamental aspects of individual differences in pain and comorbid conditions without utilizing any therapeutics or pain management strategies. So these are the only two types of trials which are allowed in this funding opportunity. So if you have a trial where you would be conducting and collecting efficacy data, that would not be responsive for this RFA. So next slide, please. So expanding a bit more on the programmatic goals and critical elements, what this funding opportunity will really enable or allow is to really support the studies that are mainly collecting data and enabling modeling as the process, as the approach, and then understanding the biological mechanisms and psychosocial aspects of pain from those models developed and validated, rigorously validated. So the same way as I just reiterate from the last couple of slides, so it's a pain occurring with a second pain condition or the use of pain therapeutics or therapeutic modalities or management strategies with other comorbid conditions, including mental health conditions, and also with or without the use of substances of user abuse like opioids or alcohol or other substance. So the program, your research program or project should really generate the data to stratify individuals with lived pain experience and collect and utilize these rigorous data structures, which can be collected from either clinical or preclinical or a combination of those to create these novel mathematical, statistical, or computational models that will enable the identification and characterization of these individual differences in people with lived pain experience. So that is really the critical point or the critical mission of this specific research program. So it should your program or your project should also utilize these clinical or preclinical data and models to provide a better understanding of the biological underpinnings and mechanisms that would basically underlie or pinpoint what are the biosocial and psychosocial aspects of mechanistic aspects that contribute to inter-individual differences in pain conditions as well as towards patient identification. Next slide, please. So here are some of the aspects or conditions where applications are not responsive for this funding opportunity. So if your application has a focus on conducting pain or disease biomarker on psychosocial biomarker studies, that's the focus of the study, so that it won't be responsive. And if your application is focused on conducting and collecting longitudinal clinical data on biosignatures or associated biopsychosocial factors without the major focus and detailed plans on the development and critical validation of these novel mathematical, statistical, or computational models, then that won't be responsive. Just collecting the data won't be responsive to. So it's a combination of collection of these data as well as developing and rigorously validating these models. And those models should actually identify or enable the identification and detailed mechanistic characterization of individual differences in pain. Then if you have a application with this direct focus on developing in vitro or ex vivo biological model system to study inter-individual differences, this is not the funding opportunity for that. And then a few applications consist of studies which involves like discovery, development, optimization of therapeutics, including therapeutics aimed at addressing inter-individual differences in pain and comorbidities, then it won't be responsive for this funding opportunity. So for those type of application, we have several other starting from therapeutic target discovery, validation to early analgesic development to optimization to safety toxicity trial to clinical trial. So those translational opportunities exist within NIH HEAL Initiative. So I would ask you to apply there. This is not the right funding opportunity for that. Next slide, please. Continuing with the couple of other non-responsive criteria. So if you are applying with a study consisting of like really evaluating potential therapeutic agents or device or efficacy or safety studies for those, then that won't be responsive. And then if you are, again, trying to focus on a study that would really develop new clinical pain management strategy or conduct clinical trial with modifications of currently approved clinical pain management strategies, then it won't be responsive here too. Okay. So if you have clinical trials designed primarily to determine the safety, as I told before, safety, tolerability, or clinical efficacy of effectiveness of an intervention, then it is not responsive here. Also, if you are trying to develop or focus mainly on developing like technologies towards collection of modeling data, if that's the focus, like you are just collecting the data as a like secondary focus with a main focus on just technology development, that's not going to be responsive here. And also other types of clinical trials that would answer specifics about tolerability, safety, clinical efficacy, effectiveness, or other management implementation of other different types of therapeutic or management strategies, those would not be responsive here. So we really encourage you to go through these non-responsive criteria, but also when you are discussing with your program officials, please take this into consideration and be very upfront to discuss on this in case you have any of these elements in your planned studies. Okay. So next slide, please. There are a couple of other important points to consider before you apply. Rigor and transparency of your study is extremely important. As you can see, the goal is to not only collect large-scale data, but also to develop and validate model. So for all these reasons, all these aspects, high rigor of your study approach, as well as your rigor of any preliminary or any other studies based on which you are developing your project. Those are extremely important, and transparency in terms of repeatability, but also sharing these models, because that's how these models can be validated at multiple places by multiple people, and that kind of develops much more strong face and construct validities for these models to be generated. The other important components are like plans to enhance diverse perspectives. This is a scored review criteria. Actually, I'll go into detail in the next slide. Also, the HEAL core common data elements, data management and sharing plans. So these three in the bold, I'll go subsequently to cover those individually, but also another important aspect is really engaging people with lived experiences and other collaborators to design your study is also very important. We really ask you to strongly consider this while designing your study. So let's go into the PDP, or the plans for enhancing diverse perspectives. What is actually PDP? These are strategies to advance the scientific and technical merit of the proposed project through inclusivity. So how you really capitalize on innovative ideas, distinct perspectives, variety of experiences, background, skill sets, other trainings, uh, that's really important to bring in and incorporate into your project. So there are three aspects, or three ways you can address the PDP. Is who does the research, basically your investigating team, how you are really enhancing the diverse perspectives there and inclusivity there. And that includes like multiple or varying career stages, varied skills from different scientific disciplines and from underrepresented populations. And then the next aspect of PDP is the who participates in the research program, like recruiting diverse participants for your human studies, and really achieving more and more diverse populations where these results from these can be much more generalized and applicable. And then the third aspect is where the research is done, what's the environment, research environment, and how diversified are those, and also how it really brings in more inclusivity, particularly looking into diverse organization institutes, specifically where institutions have less resources and they are more focusing on undergraduate and, for example, minority serving institutions, community-based institutions, and groups, how you can include those, how you can include those research sites. So that's the third pillar of this PDP. So next slide, please. So you have only one page, and that's included in the other support section. So you really have to summarize very succinctly all these strategies and how you will increase, enhance the diverse perspectives with inclusivity in a like specific, very viable timeline with milestones, and what's your specific approach. So I'm not going into very details of these examples, but I really encourage you to think more about it, read this section in the funding opportunity description, and we are happy to discuss on this. And to remind you, PDP is a scored review criteria, and it will be reviewed and scored, taken into consideration for scores in all 5 criteria of significance, innovation, investigator approach, and environment. So please take this very seriously. So the next point I want to cover, or next component, is the HEAL core common data elements, or CDEs. So the HEAL common data elements have been established to facilitate cross-study comparisons and improve the interpretability of findings across multiple clinical pain research by using core as well as extended series for patient-reported outcomes. So all HEAL, NIH HEAL Initiative supported studies that collect human data, subject data, and also planning to use the CDEs. Even the studies are outside the clinical research portfolio, we're strongly encouraging to search for applicable CDEs within the HEAL database and use the questionnaires from these databases if possible. So studies including and using these CDEs, regardless of whether they're a part of HEAL recommended repository or not, or other recommended repositories, it will be required to report which questionnaires are being used. So take that into consideration when you're designing your study. Also, HEAL clinical studies, which are using copyrighted questionnaires, are also required to obtain licenses for use prior to the initiation of your data collection. So keep that in mind. So you need to work with the HEAL Initiative Core Data Element Office to do this. So these licenses actually must be shared with the HEAL CD team and the program officials for your application prior to the use of copyrighted materials. Although you do not have to do that prior to your application, but just keep that in mind that these are the like aspects you have to be very clear in your application and post review, and if it is recommended from funding and during funding period, you have to take care of these. And also to the extent possible, all other like non-pain heal studies, if you're proposing, which or conducting clinical trials, whether it's a BESH or a mechanistic trial, or if you're conducting research involving human subjects, just like BESH studies, you are expected to use questionnaires by the HEAL CD program, if applicable and relevant to the research you are proposing. So think about that, and we have really included more detailed description on CDEs in the funding opportunity description. So the next one I want to cover is the data management and sharing plan. So as you may know that NIH has new requirements for mandatory requirements for data management and sharing plans. And these data management sharing plans need to be attached to the other plan section attachment with the forms H in the application form package. I'd like to encourage you to really see the SF 424 application guide, which gives you detail, and also within the notice of funding opportunity for this program, we have given enough details there. So you can see those elements of all the elements of NIH data management sharing plan in this NIH notice from the Office of Director. They have also provided guidance and repository selection on the data in this next notice, that's 21016. So make sure that when you are proposing your data sharing plan, you ensure that all the data you are planning to collect by the study conform to the FAIR data principles. So you can go to the recommendations on principles and other recommendations from the HEAL data ecosystem in this website listed here. So you should try to propose and be very clear on how the data, your data generated will be organized according to the standard model and whether these standard models are widely accepted within the field. There are several of these models, data models, which are accepted. We encourage you to look into those and follow many of those. Also, the clinical research programs and researchers, we are highly encouraging you to adopt and use the standardized set of data classes, data elements, and associated vocabulary standards that are specified within the United States core data for interoperability standards. So please look into these USCDI data standards and make sure that all your data collections, data elements, standards, and the vocabulary are within those standards. And again, we have included enough description within the funding opportunity description. So next slide, please. Okay, so let's go quickly onto the award, more award information. Like within the HEAL initiative, we intend to commit at least like 3 to 4 awards within the financial year 24, with an estimated total cost of $4 million for all the awards. So that's again dependent on budget appropriations. And for individual R01s, as you know, these are R01 type funding mechanism. Your total direct cost should not exceed more than $650,000 per year. And it should be, your budget should be very consistent with the complexity of your research program, what you're proposing and what are the actual needs and what facilities and others already available for your proposed project. And to remind you, normally in NIH grant systems, annual inflationary increases are not allowed, because we time to time see some applicants do try to include that, but that's not allowed. And these R01 is you can ask up to 5 years of funding support. But remember, this is one time. There is at this point, there is no chance of any renewal there. So this is 5 year. So make sure when you put your application, you really define what are your absolute 5-year outcomes and milestones there. There is no milestone document needed there, but the clear outcome and milestone, what you would achieve there, if you identify, the better it is. So at this point, I would like to hand it over to my colleague, Dr. Sarah Waller. She will take you through the application process, briefly taking you through the elements of all the application and review process. Sarah, please take it over.
Thanks, DP. And so I want to start just by saying that in order to help us plan the review, all prospective applicants are encouraged to submit a letter of intent at least 30 days before the submission due date. And so we're looking for these to be submitted by October 9th at the latest. The letter should include a descriptive title of the proposed activity, along with a summary, the names, addresses, and telephone numbers of the PD or PI, names of other key personnel, participating institutions, and the number and title of this funding opportunity, which is RFA-NS-24-021. The letter can be sent to DP. The fax number and his email address are on this slide, as well as a couple of others. Next slide, please. So the application and submission information, I do want to say first, just to be sure to follow all instructions and page limitations that are described in the SF424, along with the specific NOFO guidelines. Hopefully my audio is a little better now. Sorry about that. The standard page limits are for specific aims, one page, research strategy 12, and biographical sketch 5 pages. We'll also be looking at other project information and attachments, including facilities and other resources, the plan for enhancing diverse perspectives, which DP spent a couple of slides discussing, along with also IRB communications, which are optional. Other plans include the data management and sharing plan, including HEAL public access and the data sharing policy, along with HEAL CDEs. Again, DP had spent some time talking about that, and we're happy to address any further questions that you may have on those. The appendix will include the PHS human subjects and clinical trials information. So that's required for all studies that involve human subjects, clinical research, or NIH-defined clinical trials. The data and safety monitoring plan, which will be relevant for applications that include a mechanistic trial or a BESH trial. Also, the statistical analysis plan for any analyses that are specified in the study protocol, including how things like missing data will be handled, the rationale for sample size, or other measures to ensure rigor and transparency of the analysis. Next slide. To get a bit into the research plan, then the key elements will really are to describe the specific human pain condition or conditions and comorbidities being studied. This will, of course, include things, as DP mentioned earlier, about drug or substance use or abuse, and then the challenges associated with their clinical management related to inter-individual differences. And so we're really looking for an explanation of how the proposed research will advance the understanding of inter-individual differences in human pain conditions and comorbidities. And so the research strategy should really describe how the proposed project will either challenge existing paradigms, overcome long-standing roadblocks to progress, develop new synergies between different scientific fields to understand the biological and/or psychosocial psychosocial underpinnings of the individual differences in human pain conditions and comorbidities. The research plan should also state the significance, innovation, and approach of the proposed research, along with a detailed rationale, experimental approach, and expected or alternative outcomes for the proposed studies. It should highlight the novel multidisciplinary approach to data types and collections, data integration and modeling, and investigators with complementary expertise. The research plan should address feasibility and provide defined outcomes. You should also comment on the rigor of prior research and strategies to ensure a robust and unbiased research approach. And for all trials, the rationale for the trial design, population, and hypotheses being tested along with control group should be described, and other specific considerations for mechanistic and best trials are outlined in the announcement. Next slide, please. To go a bit over the review criteria, this will be given an overall impact score of 1 to 9. There are 5 key scored review criteria, being the significance, investigators, innovation, approach, and environment. I do want to note, like DP did earlier, that the plans for enhancing diverse perspectives, the PEDP, are assessed under all 5 scored review criteria. I do also want to emphasize that there are NOFO specific review criteria that are included in the announcement, so be sure to take a look at that. Additional review criteria that are not scored include things like study timeline, protections for human subjects, inclusion of women, minorities, and individuals across the lifespan, vertebrate animals, biohazards, and whether it's a resubmission. We're also looking at applications from foreign organizations, select agent research, resource sharing plans, authentication of key biological and/or chemical resources, and the budget and period of support. And I want to mention here again that once you've gotten a first complete draft of your research strategy, be sure to go through the specific review criteria in the NOFO and ensure that they are all met and addressed in your application. Next slide, please. With that, we'll go through a couple of key dates where the pre-application webinar is today. The application due date is November 7th, 2023. We'll anticipate the scientific merit review in March, advisory council in May, and then the earliest start date in July of 2024. There are additional due dates, and those are listed on the slide going through February of 2025. Next slide, thanks. And so finally, next steps, we can assist you with evaluating the fit with the program goals and the appropriate IC. And I would encourage you to email us for more information. DP's, Rachel, and my email addresses are all on the slide. I also have the QR code here for the specific announcement. And next slide. With that, I would like to thank you for your attendance, and Rachel will be helping us to facilitate the question and answer session.
Yeah, and thank you, Sarah, and thanks everyone again. So we'll be happy to take your questions. I think we did receive questions beforehand, like before the webinar. So we would like to address those questions first before we can go through the questions from today's Q&A. So I think, yeah,
Yep.
You want to read those? Yeah,
Sure thing. So the first question is, will novel longitudinal studies, timeframe of 20 to 30 years, be considered?
Yeah, as you can already see the duration, it's a 5-year grant period. So if you're proposing for a really long-term longitudinal study, then that's not going to be feasible here. So the answer is no.
Okay, next question. What qualifications are required to apply? Can postdocs apply? Is it open to international scholars?
Yeah, so postdocs, I mean, you cannot apply to become a PI of this. So you have to work with your institution to see what exact appointment type you have and whether that gives you or enables you for independent research administration of a project or a grant. So confirm with your institution. If they allow, then you can apply for those. And in terms of international scholars, yes, absolutely. For foreign scholars or PIs from foreign countries, they can apply, as well as if you have collaborators in foreign countries, it is allowed. The only thing really important there is you have to provide a very strong justification of why that foreign site and why or why that foreign investigator. What's the uniqueness of that? Do they have a unique data types, unique patient population, unique technology, unique analytical platform? So you have to really strongly justify like why, but it is absolutely allowed.
Great. Could you clarify whether projects that use mammalian model organisms would be considered responsive?
Yes, if you have preclinical data on mammalian model organisms, but remember that data, entire data set, should be focused, or the goal of those studies should be on understanding the inter-individual differences. If you have like extensive data, or you plan to collect extensive data to understand the inter-individual differences within those animal model or within that model, actually within individual animal differences, then yes, it is allowed.
Could you please clarify whether using existing medical claims databases or electronic health records aligns with this notice?
Yes, you could. You can utilize those data from there. But again, just the data collection would not be enough. You have to really collect like data, both bio as well as psychosocial data, if you can. And then either you can partly collect it from there, and then you are conducting your own data collection and how you model those. So those are definitely allowable there. I think those were all the pre-submitted questions, I believe.
So moving on to the question and answer box. To be considered responsive, do applications need to both generate data to develop an initial mathematical model and also validate that model? Or would studies that focus on developing the initial model with a plan to validate in a subsequent study be responsive?
No, the validation of the model must be a part of the study. Rigorous validation of the model must be a part of the study. So the last part of your question is whether the plan to validate in a subsequent study, that would not be responsive. But if you are collecting the data and developing an initial mathematical model and followed by collection of more data and validation of that model, that's absolutely responsive.
What is the definition of second pain condition? If the proposal includes patients, does that mean they will necessarily need to have two separate diagnoses of distinct pain conditions, for example, low back pain and migraine headache?
So yes, here the definition of second pain condition is in the context of multiple or overlapping pain condition. If that is your question, to understand the inter-individual differences in your specific pain condition or target population of study, that's what it means there, a second condition. Like if you have, like for example, you are trying to model inter-individual differences in chemotherapy-induced neuropathy pain condition in patients, and the specific cancer patient population and the chemotherapeutic drug type. Looking into the pain population, they have maybe substantial or maybe significant number of subjects or patients who had a history of diabetes. So that's the second pain condition. If they have, then you have to take that into account in terms of both your data collection and modeling. It's not mandatory to have a second pain condition, no. But based on what's your pain condition or patient population focus is, you if your question includes overlapping pain condition, then that's the second pain condition definition there.
Could a small business apply to this funding opportunity?
Yes, you're allowed to apply. There is nothing prohibits you, but you have to have a very strong plan of data collection as well as modeling, rigorous validation of the models to understand the biopsychosocial underpinnings of inter-individual differences. Yes.
Okay. Would clinical trials that utilize an existing drug in a new way to address a pain condition be applicable here? I know the prior slide said clinical trial testing efficacy may not be applicable.
Exactly, that's what it is. So if you are utilizing the existing or approved drug to understand how the drug works, then yes, those studies are responsive here. But if you are using a new drug, approved drug, but you are collecting efficacy data, effectiveness data, then that won't be responsive here.
How much should the application be more basic science oriented versus clinical? Should this be more population health / epidemiology versus more molecular or translational? What direction should this tilt towards more?
Yeah, that's absolutely investigator initiated. What's your question? What's your focus? And what's your approach? And ultimate goal is to understand the within individual differences and the underlying biopsychosocial mechanistic underpinnings. So the balance between basic clinical, or it could be completely clinical, it could be completely basic. So it is completely based on your research question focus and approach. So there is no like NIH is not prescriptive of what's the balance. So it's absolutely investigator initiated.
Given that you award 3 to 4 proposals per year, how many applications do you expect to receive? What is the % of proposals being funded?
I wish I could give this answer. This is all hypothetical. There is no one can predict on this. So we do not know how many we can receive the application. There is no limit, like only 10 application will be accepted, nothing like that. So we can receive as many PIs can apply. And in terms of funding, it's all dependent on budget. And as we just showed, like we plan to fund 3 to 4 applications in financial year 24. But again, that also depends on final budget appropriations from the Congress. So at this time, we cannot really predict. And percentage of proposals being funded, that's never an information which you can see even before the applications are accepted or reviewed.
Are the applications required to collect new data, or is it acceptable that the applications propose the development of modeling to understand biological mechanisms using existing data?
If you have extensive biopsychosocial and in-depth data with based on your power calculation, you have that number, depth, and quality of data, you could propose the mainly focusing on model development and validation. So that is fine. But you have to have a very strong evidence and rationale that what data exist, how extensive those data are, what is the rigor of the data, what is the breadth of the data. Sarah, just join if you want to give anything more there on this specific question or other questions too.
Yeah, thanks, DP. I think you're doing a great job of handling these.
I repeatedly heard a second comorbid condition. Are applications welcome that focus on more than one comorbidity?
If your pain condition and the inter-individual difference in the pain condition you are studying has multiple comorbidities, there are more epidemiological or incidences of more than one or multiple comorbidities, then absolutely yes, you could include.
Is there automatic prior approval for direct costs over $500,000?
So since this is a RFA and HEAL initiative, RFA funding opportunity, you would not need an automatic you would not need a prior approval before your submission. Even if your budget is more than 500K, you can directly apply. So that is absolutely fine. But to remind you, your direct costs should not exceed 650K. If it exceeds, it will be withdrawn before even coming to the program. During the receipt and referral cycle, it will be withdrawn.
Would a novel multimodal intervention be appropriate for this grant mechanism as long as the how it's working is being studied?
Absolutely. The how should be the big question, and just not how it is working should not be the major question. The major question is utilizing the intervention to understand the biopsychosocial underpinnings of inter-individual differences. How it is working, if you're trying to understand, here is a therapeutic or an intervention, and you want to study the mechanism, how it works, but not primarily addressing the inter-individual differences, then that won't be responsive. So your big question has to be, and main focus has to be on inter-individual differences and underlying biopsychosocial mechanistic underpinnings.
Would a longitudinal study determining which type of chronic pain patient responds to a proven intervention be responsive?
Yeah, if the question there, and again, the focus of the question is which type of patient and why they respond, just not which type identified, why they respond or not, and what are the differences between responders versus non-responders, and what's the underlying biopsychosocial underpinnings you can identify, then yes, it would be responsive.
Did NINR drop out? If not, who is the contact?
So at this point, NINR hasn't signed up for this, but do not worry about if your application is just fitting to only NINR, even though in the absence of NINR signing here, your application will be assigned to one of the institutes, as long as it is completely responsive to this funding opportunity.
Would projects that involve secondary data analysis of existing large data sets be considered responsive?
I think I partly addressed this before. If you're just trying to do a secondary analysis, then not. But if you have extensive biopsychosocial data sets available with enough power for your study design, and then you're developing the model to understand the inter-individual differences, that would be responsive. But if you're just proposing a secondary analysis, then it won't be responsive.
Is it allowable to propose using data from existing HEAL clinical trials for which data collection will be complete at time of funding and combined to enlarge data sets to enhance modeling opportunities?
Absolutely, yes.
Does this mechanism support co-PI applications?
Yes, absolutely. We do really encourage, because as you can see, there are two things here. One is data collection, but also mathematical, statistical, or computational modeling. So you would, as such, need complementary expertise from multiple PIs, or at least multiple investigators. So having a co-PI application would be absolutely fine and ideal, actually, unless there is a PI who have all the expertise and proven evidence on that.
Okay, applications focus primarily on technology development towards collection and modeling of data. Could you elaborate more on the definition of technology development? Is developing an AI prediction algorithm considered as technology development?
if you're, for example, if you are doing the AI prediction algorithm, you're developing that as the modeling algorithm, and then using the extensive biopsychosocial data to develop and then validate this model and bring in what the model informs, then it is allowed. But if you are proposing someone is proposing that, oh, they will develop technologies that could aid more and better data collection. So those type of technology developments are not responsive. But if you are developing technology in the form of RFA towards the data modeling side, like development of your models, so technologies to develop and aid your model or improve your model, that would be allowed.
Will applications that only focus on psychosocial mechanisms, no biological mechanisms, underlying inter-individual differences be considered?
It would not be. So that's why we made it very clear from the beginning is this program is really looking for understanding the inter-individual differences in a holistic whole person health. So if you have only psychosocial data, but you have no biological data, and vice versa, if you have only biological data, no psychosocial data, then it won't be a very responsive application. So we would urge you to really collaborate with folks, think about how you can bring in approach to collect those biological data and then combine those two together.
I think you just answered this, but could you clarify the non-responsiveness of psychosocial outcomes?
Yeah, I think that's fine. Yeah.
Is chronic pain after surgery or trauma relevant to this RFA?
Absolutely, yes. Any type of pain condition is responsive to this RFA. We're not restricting or preferring any. It's irrespective of whether it is a major pain condition or a rare pain disorder. Everything is responsive here.
Yeah, and does this RFA apply to any specialized pain condition?
That's what I just addressed. No specific one. Anything can come in.
Could you please clarify whether or not validation of the model being proposed is required to be considered responsive to this NOFO?
Yes. Just developing the model would not be sufficient. How do you validate? If you are not proposing validation of your model, then the goal is not achieved. So that won't be responsive.
Do mammalian model studies need to have a component that validates mechanisms in humans within the 5-year period?
Not necessarily, but make sure your mammalian model study to address the inter-individual differences match with the human pain conditions with that inter-individual differences. So in that case, and you are considering both the biological as well as psychosocial aspects. If you have all of those in your mammalian models, then you do not need to have the human data there. But how that model would predict inter-individual differences for that specific human pain condition and comorbidities should be very clear, and that should also be rationalized in your study design.
Can you please repeat the expected percentage of applications that will be funded?
Again, we cannot say about the percentage of applications. What we are looking for based on budget, initial budget appropriations or promises, 3 to 4 applications in financial year 24.
What is the preliminary data expectation for these applications relative to parent R01s?
That's a good question. So, you need to have a strong scientific rationale, but preliminary data support. Otherwise, it won't really give the strong feasibility. So you would need some level of preliminary data. The level of preliminary data or extent of preliminary data would depend on your question and your approach. But without preliminary data, you could still propose based on findings or reported studies or reported findings earlier. can try, but as you know, many of you are also reviewers, like that really builds into the or questions into the feasibility. So you have to just strike that balance. So feel free to write to us with your plan, and then we can discuss in one-to-one setup there.
Okay, to clarify one final time, will fully preclinical applications be considered responsive?
Yes, it can be responsive as long as it really, the goal is to understand inter-individual differences and the biological and psychosocial underpinnings of that for a pain condition. And that pain condition is modeling a pain condition in humans.
We've got a couple questions on if ESIs can be MPIs on this application. Given the focus in the call about mentoring junior faculty / students, would it be better for an ESI to be a co-I with clear mentoring in the scientific aims?
Okay, so ESIs can always be MPIs. There is no restriction there. And remember, this is a RFA. So many NIH institutes and centers, they have specific better pay line for ESIs. So there is no pay line system here. So that benefit might not be available. But remember one thing, if you are an MPI here and this grant gets funded, then you lose your ESI status for other R01s, other parent R01s, or R01s to other ICs where you might get the ESI benefit. So that won't be, and like you won't have that benefit anymore. And in terms of mentoring, yes, we do encourage to like include ESIs and other junior investigator, in fact, investigator at all career stages in your R01 applications here in this RFA.
Can you give examples of what biological mechanisms would be considered? For example, would sex be considered a biological mechanism?
Yes, I mean, sex would be one of the biological mechanisms. Other biological mechanisms constitute like specific biological underpinnings of the disorder or disease associated. Like if you, for example, are studying diabetic neuropathy, then yes, there is a like a metabolic changes as the entire biology of metabolic systems physiology changes. So those are contributing biological mechanisms alongside biological mechanisms of the pain condition itself. Like, and that includes how the painful signals are detected, transmitted, and perceived as pain. So both in the pain axis as well as the associated disease condition for the biological mechanisms.
Okay, and last question, can you please give an example of practical application stemming from this research? For example, would one outcome of this research yield better treatment matching based on individual differences given particular pain comorbidities?
Yes, absolutely, yes. So you're based on the models, it could not only identify the inter-individual differences, it might actually inform that the existing paradigm for the pain management strategies, how it can be modified. It could also inform or identify new therapeutic targets, new therapeutic modalities. So all those, yeah, are, yeah, yes, would be the ideal outcomes from these type of research investigations. Okay, I see another question just popped on.
Will only people living with pain be considered, or will people prior to developing pain also be considered for this RFA?
Oh yeah, prior to developing pain will be absolutely considered. Like one best example, if subjects without any prior history of pain, but they will be going through the, for example, surgery. So they'll acquire the post-surgical pain. So that's absolutely allowed in this RFA. How you can model pre to post pain condition development process and understand the individual differences as well as the underlying mechanisms. Yes, those will be completely responsive here. think we are a little bit out of time schedule, but if there is any other burning question, we are happy to answer. And again, just to remind everyone, please start writing to us with your plans. When you write, it would be really good if you can have a draft specific aim, or at least a summary or abstract, what you are planning to do. So then we can schedule one-to-one meetings, discussion with you and your team to shape those into how it can be responsive to this program and how you will develop and submit the application. So we'll be happy to do that. Please write to us, communicate with us. Okay, so if there are no additional questions, we can stop here. And again, as I told in the beginning, this webinar is recorded, so you'll get the recording link in the NIH website, as well as it will be sent, and the PDF of this presentation will also be sent to all the registered attendees. So good luck with your applications, and please communicate with us. And thank you again. And thanks, Sarah, Rachel, Elizabeth, everyone for helping here. Okay. Have a good afternoon, everyone. Bye.